I'm Tanya Wildes, and I'm here at the American Society of Clinical Oncology meeting here in Chicago in June of 2019. And I am discussing the management of high-risk myeloma in older adults. In my approach to managing older adults with high-risk myeloma, I consider first the disease factors that put a patient at higher risk for adverse outcomes. Traditionally, a myeloma doctor focuses on disease-focused prognostic factors, such as the International Staging System stage, chromosomal abnormalities, the revised ISS comprising the ISS plus the revised plus the chromosomal abnormalities, and things like gene expression profiling that are up and coming. However, as a geriatrician, I'm also considering the factors in that older adult's health that may put them at increased risk for adverse outcomes. When we look at the prognostic significance of specific chromosomal abnormalities, those hold truth in older adults the same as they do in younger patients, typically with a hazard ratio of between 1.5 and 2. What's interesting is that across the age spectrum, the relative importance, the relative amount that the chromosomal abnormalities impact the patient's outcomes actually decreases. And what becomes increasingly important are aging-associated factors, such as performance status. The ISS appears to increase in relevance as well, but this may be driven by aging-associated factors, such as the fact that beta-2 microglobulin is renally cleared and may really be reflecting the patient's renal function as opposed to the disease biology. So when we look at the treatment of older adults with high-risk disease through the lens of treating a high-risk disease, we turn to the literature that is applicable to this. Unfortunately, there's no single trial to tell us how to treat an older adult with high-risk disease, and we have to extrapolate from other sources of data, such as how subgroups of patients with high-risk disease have responded to certain treatments. There's been a lot of excitement about the use of carfilzomib in these patients, given that in the relapsed refractory setting, there have been improved outcomes relative to other treatments using carfilzomib-based therapy. However, we must juxtapose that with recently presented data by Dr. Facon that in the upfront setting, carfilzomib, melphalan, and prednisone did not improve outcomes compared to bortezomib, melphalan, and prednisone in newly diagnosed patients with multiple myeloma. To my knowledge, subgroup analyses looking at high risk have not been published on that data yet. However, it's unlikely that there's a benefit in high-risk patients when there isn't a benefit in the overall study. Looking at the currently available guidelines, both the International Myeloma Working Group and the recently published American Society of Clinical Oncology guidelines, along with Cancer Care Ontario, recommended use of a triplet combination in patients with high-risk disease, consisting of a proteasome inhibitor, a newer immunomodulatory agent, and a steroid. When we look at the older adults, we don't have the data to support that yet, but we have to extrapolate from what we know. And if we're looking at a fit older patient, using a similar strategy as in a younger patient is likely appropriate. When we look at our more frail older patient who may have high-risk disease factors, we may want to modulate the approach we would use in a younger patient to try and improve the chances of them tolerating that therapy. One such approach would be using a modified regimen of bortezomib, lenalidomide, and dexamethasone called RVD Light, published by Dr. O'Donnell and colleagues last year in Hematologica. In this regimen, lenalidomide is administered at 15 milligrams days 1 through 21. Bortezomib is administered weekly rather than twice weekly for 4 weeks straight and then a 1-week break, and dexamethasone is dose reduced at 20 milligrams. This regimen was well tolerated with only a 4% treatment discontinuation rate. So it appeared that in a transplant ineligible population, this modification of the RVD regimen resulted in very good response rates, but at good tolerability for an older patient. Another approach that can be used in a potentially vulnerable older adult is a start low, go slow approach, which is an approach that's used in geriatrics. The idea being, rather than starting the entire drug cocktail at once and risking the patient tolerating it poorly and having further decline from toxicity of therapy, we can use a stepwise approach. First, introducing a doublet, for example, bortezomib and dexamethasone, assuring that the patient is tolerating this combination, and then adding in the immunomodulatory to try and get that optimal disease control while not causing excessive toxicity.